You know, when you're trying to wrap your head around a complex health issue, maybe for your pet, and you just want the crucial information without getting sort of bogged down in stuff you already know or overly basic
Yeah,
explanations.
absolutely. You want the core knowledge fast.
Exactly. That's what we're doing today. We're taking a deep dive into cholangitis and cholangiohepatitis syndrome, CCHS for short.
Right. Think of it simply as inflammation affecting the bile ducts,
Yeah.
and then CCHS also brings in the liver tissue right around those ducts.
Okay. And we've gathered a good amount of information here. We're really aiming to understand this properly.
That's a perfect way to put it. It's
Yeah.
essentially a problem with the liver's drainage system
Yeah.
and sometimes the working tissue itself. And, the sources we've got cover a lot of ground.
Like what specifically?
Well, the basic definitions, of course. How these conditions actually develop, who tends to get them, mostly cats, we'll see.
Mm-hmm.
The different types, what signs you might notice,
Mm-hmm.
potential causes, risk factors, how vets figure it out, diagnosis, basically, and importantly, the treatment approaches.
So the mission here is really to pull out the most important bits about cholangitis and CCHS from all this material, make it clear, make it understandable.
Precisely. Distill it down so you get the key takeaways.
Okay, let's kick things off with the basics then. At its core, what are we talking about? What's the difference between just cholangitis and the cholangiohepatitis syndrome?
Good question. So cholangitis, in essence, is inflammation that's really localized within the bile ducts, just the ducts themselves.
Okay.
Now, when that inflammation spreads out, beyond the ducts and starts involving the liver tissue surrounding them, the liver parenchyma, that's when we call it cholangiohepatitis.
Got it. Inflammation spills over, basically.
Exactly. And what's really interesting, especially when we talk about CCHS in cats, is that it's not just one single thing. It gets categorized
How so?
based on what pathologists see under the microscope.
Yeah.
And these different categories, well, they have real implications for how we understand it and how it needs to be managed.
Right. I saw that in the sources. They mentioned several types. Can you walk us through those and maybe why those distinctions are, well, important?
Certainly. So in cats, first up is suppurative CCHS.
Huh?
The key word there is suppurative. It means pus forming.
Okay, pus. That sounds like an infection.
It strongly suggests it, yes, usually bacterial. Then there's non-suppurative CCHS. You might also hear it called lymphoplasmacytic or lymphocytic.
Bit of a mouthful.
It is. But it just means the inflammation involves specific immune cells, lymphocytes, and plasma cells. Less likely to be a primary bacterial thing, more potentially immune-driven.
Okay, immune cells, not pus. What else?
We also see lymphoproliferative CCHS. Now, this one's significant because it has a potential link to cancer,
Cancer.
specifically lymphosarcoma, a type of lymphoma. So recognizing this type is critical. It signals a need for, maybe more aggressive monitoring, different treatment considerations.
That makes sense. Any others?
And finally, there's granulomatous CCHS. This is defined by a different pattern of immune cells gathering, forming granulomas. But the really striking thing, that non-suppurative form,
The one with the immune cells.
yeah, that's actually the most common chronic liver problem diagnosed in cats.
Wow, okay. So most common chronic liver issue. Good to know. So with these different kinds of inflammation, what actually triggers them? How does this whole process get started?
Well, often it seems there are other things going on first. Pre-existing issues,
Like what?
things that cause inflammation, or importantly, obstruction in the bile ducts themselves, or even issues with the pancreatic duct.
Why the pancreatic duct?
Especially in cats, the bile duct and the main pancreatic duct often join together before they empty into the intestine. So a problem in one can easily affect the other,
Ah, okay. Shared plumbing.
pretty much. So pancreatitis, inflammation of the pancreas, that's a big one. And inflammatory bowel disease, IBD, affecting the intestines, that's relevant for both dogs and cats,
So gut health and pancreas health are tied in.
definitely. And interestingly, for cats specifically, the sources also mention chronic interstitial nephritis, CIN. That's a type of chronic kidney disease.
Kidney disease, too. It really sounds like a web of potential connections.
It really does. And you mentioned bacteria earlier. That's definitely a key player, too.
How does that fit in?
Well, bacterial infection can be the primary cause, kicking the whole thing off, especially in that suppurative pus-forming type.
Right.
But it can also be secondary. If bile flow slows down, the term for that is cholestasis.
Cholestasis, slow drainage.
Exactly. That stagnant bile can become a really good environment for bacteria to grow. So an infection can develop because of the slow flow.
Makes sense. What kind of bacteria are we talking about?
The sources list quite a few for cats, things like E. coli, Enterococcus, Klebsiella, even Clostridia and Bacteroids. For dogs, it's often opportunistic bacteria that normally live in the gut.
Okay. And can the inflammation itself cause physical changes?
Yes, absolutely. Chronic ongoing inflammation can lead to physical alterations in the bile ducts over time. You might get mineralization, like little calcium deposits, or even the formation of gallstones, which are called coliths.
So it's a complex picture, a cascade of events almost. And the type of inflammation matters, you said.
It really does. Suppurative, think bacteria.
Yeah.
Non-suppurative, more likely the body's own immune system reacting.
Okay.
Then there's a really serious one. Sclerosing or destructive cholangitis. This leads to the actual loss of small and medium-sized bile ducts. The term for that is ductopenia.
Ductopenia, loss of ducts. Why is that so bad?
Because those ducts are essential for bile flow, which is crucial for digesting and absorbing fats and certain vitamins. If you lose them, nutrient absorption gets seriously messed up.
Leading to?
Issues like those pale fatty stools we mentioned earlier and problems absorbing fat-soluble vitamins. It's a major complication.
Wow. Okay. And the other types?
Pyogranulomatous involves a mix of inflammatory cells. And again, that lymphoproliferative type is always watched closely as a potential step towards cancer.
All right. So we've got a better handle on what these conditions are and how they might develop. Let's talk about who gets them. Is it common, specific breeds, ages?
Well, like we said, that non-suppurative CCHS, that's the big one for cats, where the most common chronic liver issue they face.
So definitely more of a cat thing overall.
Generally, yes. Cats are much more frequently affected than dogs. For dogs, it's considered relatively uncommon.
Any particular cat breeds more at risk?
There are some suggestions, yeah. Himalayan, Persian, and Siamese breeds might have a higher predisposition. Needs more research, but it's noted.
Okay. And age? Does it matter?
It seems to. Suppurative CCHS, the pus-forming type, tends to show up more in younger to middle-aged cats, maybe under 10 years old typically, though the range is wide.
Sounds suppurative.
That one's more common in middle-aged to older cats. Again, a wide range, but the average age is higher.
Interesting. Any difference between males and females?
Yes, actually. For the suppurative form, male cats seem to be more prone to it. But for the non-suppurative type, there doesn't seem to be a sex difference. Both males and females get it about equally.
Huh. Okay. So, if an owner is worried, what are the telltale signs? What should you be watching for?
Well, the signs can really differ depending on the type. That acute suppurative form often hits hard and fast.
How fast?
Often the animal gets severely ill in less than 5 days. You might see significant abdominal pain, like they're really uncomfortable if you touch their belly, and often a fever.
Pretty dramatic then. What about the non-suppurative kind?
That's usually much more gradual, more insidious. The signs can be vague, maybe come and go. Things like just being lethargic, not as active, intermittent vomiting, maybe not eating as much, gradual weight loss. This can happen over weeks or even months. It could be subtle.
And you mentioned specific issues linked to that ductopenia, the loss of ducts?
Yes, that's a key thing in cats. Because bile flow is impaired, they can't absorb nutrients properly, especially fats. So paradoxically, they might actually seem hungrier. Polyphagia is the term.
Eating more but losing weight?
Potentially, or just not thriving.
Yeah.
And they might pass those pale, fatty stools, a colic stool, or steatorrhea. Plus, they struggle to absorb fat-soluble vitamins like vitamin K1, which is important for blood clotting, and vitamin E, an antioxidant.
Okay. And what might a vet find on exam?
With the acute suppurative type, they might find that fever, the painful abdomen, maybe jaundice, yellowing of the skin, or eyes dehydration, even signs of shock if it's really severe.
And the chronic non-suppurative?
Findings can be less obvious, maybe just in a large liver, what we call hepatomegaly. If they also have IBD, the vet might feel thickened intestines. Jaundice can be present, but it's variable.
What about specific signs for ductopenia in cats?
Right, besides the stool changes, they might have a really unkempt coat, poor grooming, maybe patchy hair loss, particularly along their flanks, their sides. And those stools might fluctuate in color, sort of matching the ups and downs of the disease.
Okay, so a range of signs, some quite subtle. We've covered the what's and who. Let's dig into the why again, the underlying causes and risk factors.
Sure. So for suppurative CCHS, we keep coming back to bacterial infection, right? Often linked to some kind of blockage or obstruction in the bile duct system.
Makes sense. Bacteria get trapped or thrive.
Exactly. Now, for non-suppurative CCHS, it's less about a primary infection and more often associated with other ongoing conditions.
Like the ones you mentioned earlier.
Precisely. Things like inflammation of the gallbladder itself, cholecystitis, gallstones, cholelithiasis, pancreatitis again, bile duct obstruction from other causes, and definitely IBD, in both dogs and cats.
And the kidney connection in cats.
Yes, and chronic interstitial nephritis, CIN, in cats is frequently seen alongside non-suppurative CCHS.
So summarizing the risks then for suppurative.
Risk factors would be anything that blocks bile flow, causes bile to sit there, cholestasis, gallstones, or even infections spreading from elsewhere in the body.
And for the feline non-suppurative kind,
The big risk factors listed are having IBD, having pancreatitis, bile duct obstruction again, gallstones, and that chronic kidney issue, CIN.
it really highlights how interconnected everything in that area is. Liver, gallbladder, pancreas, gut, even kidneys in cats.
Absolutely. It's rarely just one isolated problem.
Okay, so let's shift to diagnosis. A vet suspects cholangitis or CCHS based on the signs and history. How do they actually pinpoint the problem? What's the diagnostic journey like?
It's usually a multi-step process.
Yeah.
First, the vet has to consider other conditions that could look similar. We call these differential diagnoses.
What kind of things mimic CCHS?
In cats, a big one is feline hepatic lipidosis fatty liver disease. That's very common. Also, a physical blockage of the bile duct from something else, like a tumor or sludge. Pancreatitis symptoms can overlap significantly. Certain cancers, particularly lymphoma involving the liver or intestines, can look similar. Even severe systemic infections, septicemia, can cause jaundice and liver changes.
Anything else?
And especially in breeds like Persians and Himalayans, you have to think about congenital issues, like problems with how the bile ducts formed in the first place, ductal plate malformations.
Then complicating things further.
Some of these conditions can actually happen at the same time as CCHS. You could have CCHS and pancreatitis and IBD, for instance.
Wow, okay. That definitely makes diagnosis challenging. So what are the first diagnostic steps usually? Blood tests.
Yes, blood tests are crucial early on. A complete blood count, or CBC, might show some clues. In cats with severe liver disease, you might see oddly shaped red blood cells, poikilocytes, and often anemia that the body isn't trying hard to correct, called non-regenerative anemia. Sometimes Heinz bodies, too, indicating red cell damage.
What about the white blood cells?
In suppurative CCHS, you often see a high white blood cell count, especially neutrophils, and immature forms might be present a left shift, signaling that active bacterial infection.
And non-suppurative.
The CBC might actually be normal, or if there's that lymphoproliferative component we talked about, maybe high lymphocytes.
Okay, so the CBC gives some hints. What about the biochemistry panel? Liver enzymes.
Yes, that's key. You almost always see elevated liver enzymes. ALT, AST, ALP are typically high. GGT can be more variable.
Does the level tell you much?
Interestingly, the enzyme levels might actually be higher in the non-suppurative form in cats compared to the suppurative ones sometimes, but high levels are consistent.
What else on the biochem?
You'll often see changes related to bile flow problems. Variable increases in bile acids, bilirubin, which causes the jaundice, and maybe cholesterol, depending on how severe the cholestasis is, and if other issues like pancreatitis are playing a role.
So blood tests provide a lot of information, but maybe not the final answer always.
Exactly. They support the suspicion, show organ dysfunction, but often don't pinpoint the exact type of CCHS or rule out all other possibilities.
Are there other lab tests that can help?
Definitely. Vets might run a specific test for pancreatitis, like a species-specific pancreatic lipase, PLI.
To check that connection.
Right. Vitamin B12 levels are often checked, too. Low B12 can point towards gut absorption problems, like with IBD or pancreatic issues.
What about clotting? You mentioned vitamin K.
Yes, coagulation tests like PT or PIVKA are important, especially if jaundice is present or surgery is planned, to check for vitamin K deficiency caused by poor bile flow.
And for cats.
Checking the thyroid hormone level, T4, is standard in older cats to rule out hyperthyroidism, which can sometimes cause elevated liver enzymes on its own.
Okay, so a battery of lab tests. What about looking inside? Imaging, x-rays, ultrasound.
Imaging is very important. Chest x-rays might occasionally show enlarged lymph nodes there, which could hint at significant inflammation or even cancer originating in the abdomen.
And abdominal x-rays.
They might show an enlarged liver. Or, sometimes, rarely, you might actually see mineralized gallstones if they're dense enough.
But ultrasound is usually more helpful.
Much more informative for this, yes. Abdominal ultrasound lets the vet really look at the liver tissue, the gallbladder, the bile ducts.
What can they see?
They might see changes in liver size or texture, suggesting fat, inflammation, or scarring. They can look for thickened bile duct or gallbladder walls, sludge or debris inside the ducts, maybe gallstones, focal lesions like cysts or nodules. They'll check the nearby lymph nodes, the pancreas, the intestines, for related changes.
Sounds pretty thorough.
It is. But here's the kicker. Some animals, even with severe CCHS confirmed later by biopsy, can have a completely normal-looking ultrasound.
Really? So even a clear ultrasound doesn't rule it out?
Unfortunately, no.
Okay.
It's a great tool, often provides strong evidence, but it's not foolproof for diagnosing CCHS definitively, especially the non-suppurative types.
Okay, so if blood tests and ultrasound are suggestive but not conclusive, what's next? More invasive stuff.
Exactly. That's when you often need to get actual tissue or fluid samples. A fine needle aspirate of the liver is relatively easy to do.
What does that tell you?
It's mainly useful for checking for fatty liver, hepatic lipidosis, or sometimes catching obvious infection or cancer cells. But for diagnosing non-suppurative CCHS, it's generally not reliable. The sample's just too small. You can miss the patchy inflammation.
Okay. What about sampling the bile directly?
That's called cholecystocentesis, putting a needle into the gallbladder, usually guided by ultrasound, to get a bile sample. This is really good for looking for infection, culturing the bile, and sometimes finding abnormal or cancerous cells. Normal bile has very few cells.
But the gold standard.
Often comes down to a liver biopsy, getting a piece of liver tissue for microscopic examination. This is usually needed for a definitive diagnosis, especially for non-suppurative CCHS.
How do they get the biopsy?
A couple of ways. Needle biopsy, often guided by ultrasound, or surgical biopsy. Needle biopsies are less invasive, but again, small sample size is a limitation. You might just miss the diseased area if it's patchy.
What about surgical options?
You can do it via laparoscopy, minimally invasive keyhole surgery, or a full open surgery, a laparotomy. These allow the surgeon to see the liver directly and take larger multiple samples from different areas.
Is one preferred?
Laparotomy, the open surgery, is often recommended if there's a strong suspicion of a bile duct obstruction, because the surgeon can explore thoroughly and potentially fix the blockage at the same time. Laparoscopy is great for sampling, but not ideal if you think there's a blockage you need to relieve.
And if non-suppurative CCHS is suspected?
It's really important to also biopsy the intestines and the pancreas at the same time, given how often IBD and pancreatitis are involved.
Makes sense. Check all the linked organs.
And crucial with any biopsy or bile sample. Send for bacterial culture. You need to know if infection is present.
Anything else on the diagnostic front?
Just a minor point in breeds prone to polycystic kidney disease, like Persians. Genetic testing for that might be relevant if cysts are seen on ultrasound, as liver cysts can sometimes occur too.
Okay, a very comprehensive diagnostic approach needed sometimes. So when they do get that liver tissue, what does it actually look like? What are the pathological findings?
It depends on the type, of course. With suppurative CCHS, the liver might look swollen, maybe discolored, reddish, or mottled. You might see signs of inflammation on the gallbladder surface, or obvious pancreatitis nearby. Lymph nodes are often enlarged, maybe visible bile duct blockage or cysts.
And non-suppurative?
The liver might be enlarged, or normal size, or even small and shrunken if it's very chronic and scarred. It often feels firmer than normal. The surface might look irregular or nodular. Gallstones or cysts could still be present.
What if fatty liver is also going on?
Then the liver typically looks distinctly yellow, feels very greasy and fragile, and pieces might actually float if you put them in formalin preservative, which normal liver doesn't do.
Okay, clear visual differences depending on the process. So let's move on to treatment. We know what it is, how it's diagnosed, how is it actually managed?
Right. Treatment really hinges on whether it's the acute, likely bacterial suppurative form or the chronic, likely immune-mediated non-suppurative form, and how sick the animal is, of course.
Let's start with severe suppurative CCHS. What's the approach?
These animals are often very ill, so hospitalization is usually required. The cornerstones are aggressive intravenous fluid therapy to correct dehydration and support circulation, and broad-spectrum antibiotics.
What kind of antibiotics?
Initially, something that covers the likely gut bacteria, maybe like ticarcillin with clavulanate, or a fluoroquinolone like enrofloxacin combined with metronidazole to cover anaerobic bacteria. Ideally, you adjust based on culture results later.
How long do they need antibiotics?
Usually for a long time, at least 4 to 6 weeks, often longer, even after they seem better. You also typically start medications to help bile flow, like ursodeoxycholic acid, UDCA, and maybe antioxidants like thosam.
Okay. What about prepping for biopsies in the non-suppurative cases, especially if they're jaundiced?
Good point. For jaundice cats suspected of having non-suppurative CCHS, giving vitamin K1 injections for a few days before a biopsy is standard practice. to reduce the risk of bleeding since their clotting might be impaired.
Might they need blood transfusions?
It's possible, yes. Some cats, especially if they're very anemic or have clotting issues, might need a transfusion after a biopsy or surgery.
And fluids. Any specifics there?
Generally balanced electrolyte solutions. Sometimes they need extra potassium or B vitamins added. It's usually recommended to avoid fluids with dextrose, especially in critically ill cats, as it could potentially worsen or trigger fatty liver.
Okay, so that's the initial intensive phase. What about managing things long-term or as outpatients?
Right. Once the crisis is passed, or for managing chronic non-suppurative cases, the focus shifts. For non-suppurative CCHS, where no bacteria were found on culture, long-term immune modulation is often the key.
Along with other supportive meds.
Yes, often continuing with antioxidants and liver protectants like SAMe or vitamin E, and possibly UDCA, although we'll come back to a caveat with that. Rest is important during flare-ups. And diet is huge.
What kind of diet?
For cats, generally a high-protein, high-calorie diet to maintain condition. Supplementing water-soluble vitamins like B vitamins is common. If IBD is present, sometimes a novel protein or hydrolyzed diet and antigen-restricted diet is tried.
What if they have trouble with fats, like with ductopenia?
Then a fat-restricted diet might be necessary. And sometimes, if they're not eating enough on their own, a feeding tube might be placed temporarily or even long-term to ensure they get adequate nutrition. Parenteral nutrition, IV feeding, is rarely used due to the risk of fatty liver.
It sounds like non-suppurative CCHS is often a lifelong management situation.
It usually is, yes. The goal is remission and good quality of life, but it often requires ongoing treatment.
What about surgery beyond biopsies? Is it ever curative?
Sometimes. If the main problem is, say, cholecystitis, inflamed gallbladder, removing the gallbladder, cholecystectomy, can resolve that aspect. Procedures can be done to bypass obstructions if they can't be removed. Gallstones can be surgically removed.
Any downsides to surgery?
Well, any surgery has risks. And one specific procedure, connecting the gallbladder directly to the intestine to bypass the duct, a cholecystoenterostomy, while sometimes necessary, does increase the long-term risk of bacteria traveling up into the biliary system, causing recurrent infections, septic cholangitis.
Okay. Let's dive deeper into the medications used. You mentioned antibiotics for suppurative. What about the immune drugs for non-suppurative?
Right. The mainstays are glucocorticoids, like prednisolone.
Not prednisolone.
Not for cats, no. Cats don't convert prednisone to the active form prednisolone very well. So always prednisolone for cats. The dose is usually higher initially, then taper down for long-term use. But you have to monitor for side effects, and there's a risk of causing diabetes in cats, especially with long-term use.
What else besides steroids?
Metronidazole is often used in combination with prednisolone. It has some immune-modulating effects itself, plus it targets anaerobic bacteria, which can be relevant if there's underlying IBD.
What if the CCHS is more severe, like that destructive type with ductopenia?
Then more aggressive immunosuppression might be needed. Azathioprine is generally not recommended for cats due to severe side effects. Instead, combinations might be used, like prednisolone and metronidazole, plus either pulsed methotrexate therapy or chlorambucil.
Methotrexate or chlorambucil, those sound like chemotherapy drugs.
They are, but used at lower doses for their immune-suppressing effects here. There are specific protocols, especially for methotrexate and feline sclerosing CCHS, often involving injections and needing concurrent folate supplementation. Chlorambucil is usually given orally.
What if that lymphoproliferative type is found, the one close to cancer?
If the biopsy confirms it's leaning towards or actually is lymphoma, then standard chemotherapy protocols for intestinal lymphoma would typically be recommended.
Okay, that covers immunosuppression. What about antioxidants?
Very important. Vitamin E is commonly used. Higher doses might be needed if there's significant bile obstruction or ductopenia, because fat absorption is poor. There's even a water-soluble form available for those cases.
And same.
Yes, S-adenosilmethionine, same. It's a precursor to glutathione, a major liver antioxidant. It also seems to have some anti-inflammatory effects. It's often used especially in milder non-suppurative cases, sometimes even helping achieve remission on its own. Use a bioavailable veterinary formulation.
You also mentioned UDCA, ursodeoxycholic acid. What does that do?
UDCA has multiple benefits. It's considered liver protective, helps bile flow, has some immunomodulatory effects, might reduce scarring, and acts as an antioxidant. It's been a cornerstone for years.
But you mentioned a caveat.
Yes, there's some more recent information suggesting that in certain types of chronic cholangitis in cats, specifically the destructive or sclerosing kind where small ducts are being damaged, UDCA might potentially worsen that small duct injury.
Oh, so use with caution.
The current thinking is that it's probably best to have a liver biopsy diagnosis before starting UDCA. In cats suspected of having chronic non-suppurative CCHS, just to be sure you're not dealing with that specific destructive form where it might be counterproductive.
That's important new information. Anything else with UDCA?
If cats are on it long-term, they need taurine supplementation, as UDCA can deplete taurine.
Okay. Any other supplements or meds?
B vitamins are often supplemented, especially B12, as we discussed, due to malabsorption. Thiamine, vitamin B1, is also important, as deficiency can occur with liver disease or poor appetite. Specific doses are used.
Are there concerns about using drugs in animals with liver disease?
Absolutely. Drug dosages may need to be adjusted based on how well the liver is functioning and whether bile flow is adequate for excretion. And some drugs, like metronidazole, carry a risk of neurotoxicity, especially at higher doses or in jaundiced animals. Careful monitoring is key.
How is progress monitored long-term?
Regular follow-up visits and blood tests are essential, especially for non-suppurative CCHS. Monitoring liver enzymes and bilirubin levels helps track response to treatment and detect flare-ups. Though, interestingly, UDCA can interfere with serum bile acid tests, so those become less useful if the animal is on UDCA.
Can anything be done to prevent CCHS?
Well, since IBD and pancreatitis are major risk factors, effectively managing those conditions if they're present might help reduce the risk of developing CCHS, particularly the non-suppurative form.
What are the potential complications down the road?
Suppurative CCHS could potentially progress to a non-suppurative or even sclerosing form over time. As mentioned, diabetes mellitus is a risk in cats treated long-term with prednisolone. And hepatic lipidosis, fatty liver, can develop secondary to CCHS if the cat isn't eating well, or sometimes triggered by steroid use.
And finally, what's the expected outcome? The prognosis.
For suppurative CCHS, if caught early and treated aggressively, sometimes a cure is possible, especially if an underlying cause like a stone is removed. For non-suppurative of CCHS, it's typically considered a chronic condition requiring lifelong management. However, with appropriate treatment, long-term remission and good quality of life are definitely achievable for many pets.
Okay, that was incredibly thorough. So, pulling it all together for you, the listener, the key takeaways seem to be cholangitis and cholangiohepatitis syndrome are inflammatory issues of the bile ducts and often the liver around them. Cats are primarily affected.
Right, and there are different forms, some linked to bacteria, others more immune-related, some quite serious, like the destructive type, or those potentially leading to cancer.
Diagnosis often requires more than just basic tests. Biopsy is frequently needed to know exactly what you're dealing with.
Absolutely. Early and accurate diagnosis is critical.
And treatment depends heavily on the type. It can range from antibiotics to long-term immune suppression, antioxidants, dietary changes. Often it's a long-term commitment, especially for that common non-suppurative form in cats.
That sums it up well. It's complex, but manageable with dedicated care. This deep dive really covered the crucial aspects from the sources.
It really did.
Yeah.
You know, considering how interconnected we've seen, the liver, gallbladder, pancreas, and even the intestines are in these conditions, it really makes you think, what other health issues that seem localized might actually have these broader systemic roots that are worth exploring more deeply?
That's a great question. It certainly underscores just how intricate the body is and why understanding those connections is so important in veterinary medicine.